Thank you very much. Good afternoon. Our case today is called When One Door Opens, Other Close. As you will see, we have a 55-year-old male with a BMI of 30, hypertensive, and positive family history of coronary artery disease. He had accelerating angina over the past 2 weeks. Investigations were normal, ECG was normal. He had an ejection fraction of 55%. He was put on medical therapy, but then did a coronary angiography. This coronary angiography, at first, my colleague said it's a normal coronary. I said, no, it's a totally occluded LED, of course. And as you see here, we did a retrograde injection from the right coronary, showing some septal collaterals and showing that it's a long segment CTO, more than 20 millimeters, and an ambiguous stump. We put a wire in the diagonal, and we did an IVUS to see the opening or the opening of the stump of the total LED to know where to puncture. Our first trial was actually out of the way, of course, and we did an IVUS guided puncture. As you see here in this algorithm, we have an proximal cap ambiguity. You do a IVUS guided re-entry, and the distal vessel quality is not so good, so you start with an antegrade approach. You put the IVUS catheter in the diagonal, and you see, as you see here in the left-hand side at 9 to 11 o'clock, this is the opening, or this is the stump of the totally occluded LED, and you go with the wire inside this stump. So that's exactly what we did. We used the Caravel microcatheter. We tried the Fielder and then a Conquest Pro. No, Gaia Third, sorry. Gaia Third. As you see here, we were just close to the distal part of the vessel. And then we entered and we replaced it with a BMW wire over the microcatheter. As you see here in the retrograde injection, shows that the wire is totally in the true lumen distally. We did the PTCA with a 1.5, then with a 2.5 millimeter balloon. And then an IVUS to determine the proper sizing of the mid LED. It was a 3.0 vessel, and then a 3.5 to 4 from the left main LED. So we have a wire in the LCX and the wire in the LED, and after ballooning, that's what we found. The patient started to develop chest pain and blood pressure drop. So we put a stent, a 3x38 in the LED, and then a left main LED stent with 3.5, and then a pot. And unfortunately, the other 3 vessels closed. The patient crashed. I wired the ramus and the high OM. It was very difficult to wire this ostial LCX through the struts of the stent, even after a 4.5 NC pot. So what happened here was a subintimal shift. We entered first in the subintimal space. So with ballooning and opening of the stent, there was a shift of this subintimal, of this dissection flap, and it closed the 3 vessels. So I tried with a Conquest Pro, and it was the only wire that was able to pass this, to puncture this flap and enter into the CX. Then ballooning with an NC balloon, and then with an NC 3.0 in the ostium, and it opened, and then pot and a kissing with a drug-coated balloon in the LCX, then a final pot, and that was our final result. So my take-home message is that IVUS is a very good tool for success of antegrade opening of the ostial bifurcation lesions with ambiguous proximal cap. We should always take care of the ostial LCX when we deal with ostial LED CTOs to avoid this subintimal shift. Be ready for all troubleshooting that may happen, antegrade or retrograde. Thank you.